Good morning, everybody. I'm starting a few minutes early. This is Nurse Eunice with Florida Training Academy, and in today's video, we're going to review a patient care technician or a PCT practice test. And if you're unaware, a PCT is the hospital version of a CNA. So yes, once you pass your CNA exam and you become licensed as a nursing assistant, when you go apply at a hospital, they're not going to ask about your, necessarily your CNA skills. They have to teach you more skills. So that is when you become a patient care tech and you learn how to take care of more sick or more critically ill patients. And so we'll give you about 10 seconds to receive your notifications. And I am so excited because like 5 people have contacted me to say that they have passed their tests in just the last 24 hours. And my mom is improving and she was walking the day. So I'm super excited. We have a long video today. We have over 40 questions, so let's get started. Question number 1, everybody. What is the primary purpose of an EKG? And some of you were already putting your answers in. I saw you. Is it A, to measure blood pressure, B, to assess electrical activity of the heart, C, to measure oxygen levels in the blood, or D, to assess lung function? Good morning, everybody. Let's see. Iris, Cleo, Natasha, Karen, you are absolutely correct. So, as a patient care tech, you'll learn additional skills such as how to actually perform or conduct 12 lead EKGs. And so, the reason why you'd be doing so is B, to assess the electrical activity of the heart. And so, those electrical changes, what we see on the EKG reading, can let the staff know if a person's having heart conditions or if maybe their chest pain is not heart related. So those EKGs are extremely important. And for those of you all, if it's your first time here, I'm the owner of Florida Training Academy. Our website is fltraining.com, but we also do online patient care technician classes for the US only. So you have to be a US citizen in order to take this national certification, but you can get more information by calling us at 877-225-7151 or just going to our website, FL Training, and clicking on Online Patient Care Tech Program. Let's go to question number 2. What should you do if a patient has a hairy chest before placing the EKG electrodes? Is it A, place the electrodes over the hair, B, shave the hair where the electrodes will be placed, C, ask the patient to shave the hair later, or D, apply extra gel on the electrodes? What do you think, team? Oh, you all are fast and you are correct. It is B. So let me tell you why I chose this image. All right, so in this image, she whacks the chest. But pretty much when you're putting these electrodes everywhere on a patient's body and they have a hairy chest, you're only shaving the area where the electrodes are going to go. So they could literally have like a patchy chest. And we typically don't shave a patient's entire chest because when it grows back, number one, it could be itchy, but you will just be shaving the area where you will be applying electrodes. Otherwise, they won't get to the skin and you're going to have some irregularities with your readings. It won't be as accurate. Question number 3. What might cause artifact on an EKG tracing? A, patient movement, B, incorrect lead placement, C, electrical interference, or D, all of the above? Marilyn, I'm so proud of you. Congratulations on passing your exam. You all make me so proud. Oh, this was an easy one. And yes, everybody has it right. It is D. And so it is all of the above. So the patient moving, you didn't follow the instructions and put the leads on right away, or maybe the system is just not working properly. But I chose the image of this woman because she looks feisty. You're going to tell her to lay still and she's going to probably move anyway. So get your patients to actually cooperate, to lay still, and to make sure that it's not a whole bunch of hair on their chest, etc. That will help you get the best EKG reading possible. Question number 4. What is the first step in performing a venipuncture? That's right. As a patient care technician, you can draw blood. Is it A, insert the needle, B, apply the tourniquet, C, clean the puncture site, or D, identify the patient? What do we do first? We're about to go in this room and draw some blood. I see C's. I see a lot of C's. So it's a toss up between C and D. But if you chose D, you're right. Look, just don't go in there randomly sticking people. We need to make sure that you're drawing the blood on a correct patient. So D is the correct response. Before you start your venipuncture, you verify that you have the right patient. You have your lab slip, you have your requisition. You want to do two patient identifiers. So you're just not going to go in and say, hey, is your name Eunice Mathis? Because I could be confused and I would say yes to everything. So what you do instead is say, can you tell me your name? And can you tell me your date of birth? That would be two patient identifiers. You verify the patient's name on the actual armband, and then you verify that information against your lab request slip. And that will help you to ensure that you're drawing the blood on the right patient. If you happen to be working in a lab, per se, and you're going to like nursing homes and they may not always have on armbands. At that point, you can ask the nurse to identify the patient. Question number 5. Which vein is most commonly used for venipuncture? Is it the brachial vein, the cephalic vein, the basilic vein, or the median cubital vein? Ooh. I'll reveal the answer in 3, 2, and it's okay if you get it wrong. Give me an answer, team. It is D. So it is the median cubital vein. And so the median cubital vein is most commonly used because it is large and well anchored. And so I have an illustration here. You all can always come back later and just pause and review the slides in the actual video. But with the palm up, the cephalic vein runs along the thumb side. The basilic vein runs along the pinky side. And the median cubital vein is that large vein that you'll usually see in the center of the arm, and we call that the antecubital area. So if you're drawing blood and your patient has a cubital vein present, that's what you want to palpate. That is where, when I say palpate, you're going to be pressing to make sure that it is not pulsating, because we don't ever want to perform venipuncture on something that's pulsating. If it's pulsating, it's an artery. A vein would be soft and spongy, and that's where you insert your needle. All right, question number 6. How long should a tourniquet be left on a patient's arm? Is it 1 minute, 20 seconds, 2 minutes, or as long as it takes to collect the specimen? Let us see, let us see. I'm seeing some answers coming through. And so for you all, the correct response is 1 minute. Yes, Chrissy, all you get is 1 minute. So let's say there's a delay. You find the pulse, excuse me, you find the artery, not the pulse. Let me rephrase that. You find the vein, and let's say there's a delay and you actually doing the venipuncture attempt. You'd have to take off the tourniquet, then put it back on. Make sure you re-clean your site, but you're not supposed to keep the tourniquet on for longer than 1 minute because it can cause the blood to hemoconcentrate. It can also cause the blood to clot. So 1 minute is all you get. Question number 7. What is the correct angle for needle insertion during a venipuncture? Is it A, 15 to 30 degrees, B, 30 to 45 degrees, C, 45 to 60 degrees, or D, 60 to 90 degrees? Think about that phlebotomist when he or she is drawing your blood. At what angle do they insert that needle? Talisha, congratulations on passing your test also. And I'm happy that I'm able to teach you all some new things, because I see that the patient care tech part is a little harder for you than the CNA test. So it is A, 15 to 30 degrees. The way I like to think about it is whenever you're inserting that that needle into a vein is similar to a aircraft pilot who is landing a plane. We don't want to nosedive. We don't want to be too high up because we're going to go through the vein. So about 15 to 30 degrees is the correct angle for needle insertion. All right, and so here's another illustration. Of course, the red section represents blood. So whenever you enter the vein from above or on the side of the site, you should puncture the vein at a 15 to 30 degree angle with the bevel of the needle facing up. And then you want to slightly decrease the angle of the needle once you enter the vein and insert a fraction further. Do not force that vein. Don't thread that needle into the vein because you're going to cause trauma to your patient. Question number 8. Why is it important to invert blood collection tubes after drawing blood? Is it A, to mix the blood with the anticoagulant, B, to prevent clotting, C, to ensure accurate test results, or D, all of the above? And I'm doing my nurse dance because I know everyone's going to get this answer right. You're going to get this answer right. Revealing the answer in 3, 2, and yes, I am blessed. Karen, Nancy, Chrissy, you all are absolutely correct. It is D, all of the above. So when you invert those tubes up and down, mixing the additives that are already in the vacutainer, it's going to help to prevent clotting, and it also ensures accurate test results. So we always mix, we just don't mix it too vigorously. Question number 9, what is the primary purpose of a tracheostomy? Is it A, to provide nutrition, B, to deliver medications, C, to maintain an open airway, or D, to assist with urination? And if you watched yesterday's video, you know this answer. Revealing the answer in 3, 2, and everybody has it right. You all are so smart. It is C, to maintain an open airway. So a tracheostomy is a tube that's inserted into the trachea. Maybe this person had anaphylaxis. Maybe they're just having some severe breathing difficulties. And so if we intubate them, if we do an oral intubation, we call it endotracheal tube, we can't leave that in for too long. We can probably leave that in for about a week. But if we can't wean them off the vent, we're going to have to find a more permanent airway. And that is when we will insert a tracheostomy. Question number 10, which of the following is an important aspect of tracheostomy care? Is it A, changing the drainage gauze, B, suctioning the tracheostomy tube, C, monitoring for signs of infection, or D, all of the above? And I made some of these questions super easy as far as the answer options because the care that my mom received in the hospital recently, I couldn't ever be a daughter. I always had to go there and be the nurse, and I don't like doing that. So I need for you all to be thinking outside the box. Yes, you're going to be a CNA, or yes, you're going to be a PCT, but you're going to be there monitoring that patient and notifying the nurse when something is wrong. So if somebody has a tracheostomy, you're going to do all of the above. All of those are tasks that are important in tracheostomy care. So the response is D. Question number 11, how often should tracheostomy ties be changed? Is it every day, every shift, as needed, or once a week? And for this one, I will take 2 different answers. Yes, yes, yes. So Harriet, Karen, Nancy, Tana, yes, and also I am blessed. So as needed, or at least every shift. So tracheostomy ties should be changed as needed, especially if they become soiled or loose. And as I spoke on yesterday, it always takes two people to change those tides, because if one person tries to do it by themselves, the patient may move and their tracheostomy tube can become dislodged. So usually as the PCT or the tech, you're there just making sure you're holding one side while the nurse unties everything on the opposite side. And once she secures that side, you all would trade places. Question number 12. What is the purpose of humidification in tracheostomy care? Is it to provide nutrition, to assist with breathing, to deliver medications, or to prevent the drying of the airway? Humidification is important with oxygen therapy. Why? And if you said D, you are correct. All right, so the question spoke of tracheostomy, but I'm trying hard not to get in trouble with YouTube this month. So I couldn't show you an image of a mucus plug. What I want you to see is how dry this person's lips are. And so whenever someone has a tracheostomy, hot air is being delivered through their tracheostomy if we don't humidify it. So what you see externally there on this patient's lips will happen internally if we don't use a humidification system. So that's why whenever someone has a large amount of oxygen flowing through, we usually will humidify the oxygen, and that's going to prevent it from drying out their respiratory system. Question number 13. What should you do if a tracheostomy tube becomes dislodged? And this one is a no-brainer. Are you going to reinsert it, call for help, leave it out, or cover the stoma with a bandage? And remember, you're a patient care tech. Some things are above your pay grade. So what are you going to do? Yes, Claudia. Yes, Nancy. Oh, you're calling for help. You're going to get help in that room right away because that is a medical emergency. So the correct response is going to be B. You're going to call for assistance, and usually the nurse will take care of the emergency, and you're going to run out and get the extra supplies that she needs. There should always be an emergency trach at the bedside. So you should never be running out to get an emergency trach, because one should already be at the top of that patient's bed in case of dislodgement. Question number 14. What is a common reason for placing a gastric tube? Is it to deliver medications, to provide nutrition, to relieve gastric distension, or all of the above? A gastric tube, it could be in their nose or it could be placed directly in their stomach. If it's in their nose, we call it a nasogastric tube. If it's in their stomach, sometimes you'll hear it called a PEG tube or a G tube. But why do we place those? Couldn't fool not one of you. Yes, the answer is D, all of the above. And I hope that this patient survived. She has a nasogastric tube. So she has a tube going from her nose that's going all the way into her stomach. But on top of that, she also has an endotracheal tube, which means that she was having breathing problems and they had to intubate her. So you're going to have some patients, remember, patient care tech is hospital level. So you're going to have some patients who have multiple tubes coming out of their face. And this would be one illustration. But those gastric tubes, they can provide their medications through it. We can feed them through it. But let's say she started throwing up, we can connect it to suction and then suck out those stomach contents. And we call that decompressing. Question number 15. How should you confirm the placement of a gastric tube before use? A, by checking for stomach contents. B, by listening for air entry. C, by using an x-ray. D, all of the above. So don't just think about you. Think about that whole nursing team. You just helped me insert a nasogastric tube. What do you think would be the best ways to actually confirm that it's where it's supposed to be? And you are absolutely correct. It is all of the above. So the response is D. So tube placement can be confirmed by checking for stomach contents, listening for air, and using an x-ray. So you all, anytime someone has a nasal gastric tube or a gastric tube, you see that large syringe? That's an irrigation syringe. And so that would be something that you would be getting as a patient care tech. When we tell you to go get supplies, we use this syringe to initially at first, we just instill air while the nurse is listening to the epigastric area. And that will be one way to confirm placement. After we confirm that it's in the right spot, then we can pull back and we call it aspirate, and we can aspirate the gastric contents. However, the best way to confirm placement is with an x-ray, because it will show us if it's in the right position and if it's down far enough. Question number 16, and today we have over 40 questions. So I hope that some of you all can stay with me the entire time. If not, I do understand. I hope that you come back later and just continue reviewing for the patient care technician examination. Question number 16, what should you do if a gastric tube becomes clogged? A, leave it and try again later. B, use a carbonated beverage to clear the clog. C, replace the tube. D, flush it with water. In Jesus House of Shiloh Ministries, I must have missed a question because all I see right now is international. I'll try to pay more attention to the chat. And for everyone who said D, flush it with water, you're absolutely correct. There's that irrigation syringe again. So flushing it with water is the first step to clear a clogged gastric tube. And the next step is to prevent it from happening in the first place. And we'll talk about that on subsequent slides. Question number 17, what is the appropriate position for a patient during a gastric tube feeding? All right, so we're in the hospital. You're taking care of this patient. They have to have a tube feeding. We have them connected to the pump. What position do you want them in? Is it supine, prone, semi-Fowler's, or Trendelenburg? All right, bring it forward. What do you think? What position do we want to put someone in if they are receiving feedings? They may not be receiving oral feedings, but it's still a feeding. And for everyone who chose C, you are correct. So the semi-Fowler's position is them sitting upright. It's not a full 90 degrees because sometimes if we sit them up too high, we can cause them to get a pressure sore. But a general rule of thumb is anybody who has a tube feeding automatically is going to be up at least 30 degrees all day. The exception is whenever you have to reposition them, you have to change them, wash them up, at which point I have a comment under the image here. It says pause the pump if you have to lay the person down. Otherwise, you're still feeding the person while they're laying flat or supine, and that's going to put them at risk of aspiration. And if you forget to restart the pump, no worries. Every 5 minutes, it's going to beep at you. So it's going to remind you to restart it, but make sure you pause it in order to lay the person down, complete your care, raise them back up, and then you restart your feeding. Question number 18, how often should gastric residuals be checked? Their stomach contents. You're feeding me via a gastric tube. How do you know if it's digesting? How often do you want to check it? Is it every hour, every 4 to 6 hours, once a day, or follow the instructions in the care plan? And I will accept 2 answers for this one. Letitia says D. Sharon says B. Shay says D. And we'll see another response in 3, 2, and everybody is a toss-up between the 2 answers I chose. All right, so it's going to be every 4 to 6 hours, or D, whatever your nurse has in her notes over there is what you'll do. You'll follow the care plans. And that is because gastric residuals are typically checked at least every 4 to 6 hours. However, if your patient's having complications such as they're not digesting the feeding, residuals may have to be checked more frequently because we don't want to keep putting food, even if it's liquid, on top of someone's stomach if they're not digesting it. Because if we do and we lay them down, there's that A word again, that food can come up and they're going to be at risk of aspirating. Question number 19. What should a PCD do if a patient with a tracheostomy shows signs of respiratory distress? A, increase the oxygen flow rate. B, suction the tracheostomy tube. C, call for immediate medical assistance. Or D, remove the tracheostomy tube. Your patient with a trach is having breathing problems. I'm so proud of you. You call for help immediately. The response is C, because that person probably needs care that you can't provide. They need that nurse in there. Question number 20. What is the first action a PCT should take if a patient begins to bleed excessively during phlebotomy? Is it A, apply a tourniquet above the site? B, call for medical assistance? C, apply direct pressure to the site? Or D, remove the needle and bandage the site? All right, so you're in there, you're drawing blood on Miss Lucas, and she starts to bleed. I see C's and I see B's. I'm not going to be happy with you if you didn't apply pressure and you call me in that room. So So you can call for help after you do C. I need for you to apply direct pressure to the site because that's going to immediately control the flow of the blood. If I'm in room 19 and you're in room 1 and you're calling for help, it's going to be 5 minutes before I get to you. That's going to be a lot of blood loss. And so what I have here is Coban self-adherent tape. So when someone is a bleeder, you don't want to just put a gauze and a band-aid, because as soon as you leave and you remove the pressure from your hands, the direct pressure, they're going to bleed through. So you're probably going to have to hold pressure for about 3 to 4 minutes until the bleeding stops, but then know that it can still bleed. So you take a folded gauze, put it on top of the puncture site, and you would wrap it with the Coban. And that's going to apply pressure. And the wonderful thing about Coban is that it sticks to itself and it doesn't stick to the sensitive skin. So it's not going to irritate the patient's skin as you wrap it around their arm. Question 21. What is a critical aspect of caring for a patient with a gastric tube? Is it A, monitoring for signs of infection, B, ensuring the tube is secure, C, checking for proper tube placement, or D, all of the above? Easy, easy, easy. The test gets harder as we go along because I won't have as many all of the above options. But if you chose D, you are correct. So look at this. This is someone's gastric tube. Look at how neat that dressing is. Look at how the tape is. It's not totally, we didn't like over tape. We kind of like do like a window pane taping method. But as a CNA, as a patient care tech, you should be monitoring this, because if the drainage gauze becomes soiled, or if it isn't in a lock position, you want to let your nurse be made aware. So what you do matters, and it helps to keep our patients safe. Question 22. When performing phlebotomy, what should you do if a patient feels faint? A, continue the procedure quickly. B, have the patient lie down. C, offer the patient water. Or D, stop the procedure and call for help. I see the correct answer is coming through. So yes, everybody, because this patient may not have been faint because of your, newly acquired phlebotomy skills. They could be faint because they're diabetic, their blood sugar could be low, because their blood pressures are low. So I want you to think of this whole clinical picture. You're going to be called into a sick person's room to draw their blood. And yes, if they start bleeding, you apply pressure. But if something else medical happens, you're going to do D. You stop drawing the blood and call for help and get those nurses and those doctors at the bedside. Question number 23. Now we're getting into EKGs again. I don't expect for you to know this. We're just going to guess. What does the P wave represent in an EKG tracing? Is it A, atrial depolarization, B, ventricular depolarization, C, atrial repolarization, or D, ventricular repolarization? I see some B's, I see some C's, and again, you always can come back later and look at these slides. I see a D, and the P wave is the party starter. So whenever we're starting the party, we're kicking it off. And we kick it off with A, atrial depolarization. So the P wave represents atrial, that's the top of the heart. Depolarization, which is electrical excitation of the atrial in the heart, and it causes the top part of the heart to contract. So the blood pushes from the top part, which is the atrium or the atria, down to the bottom part, the ventricles. And on the next slide, I have an image which represents the cardiac conduction system. And so, if you're interested in learning more about all these things that I'm telling you about, just call the number, go to our website and find out more information about our online PCT certification courses. But the atria is the top part of the heart and the ventricle is the bottom part of the heart. So it starts off, blood flow starts off at the top due to the electrical conduction system. And then once the atrial depolarize, it pushes the blood out into the ventricles. And from the ventricles, when they depolarize, it pushes the blood out to the rest of the body. And that is part of your cardiac cycle. Question number 24. Which of the following can cause an elevated ST segment? Is it hypocalcemia, hypokalemia, myocardial infarction, or sinus tachycardia? Oh, I know you all are learning a lot today, picking those brains. ST segment elevation. I see an A. I'll wait for 3 more responses before I reveal the answer. I see a D. I see a C. And Ruth, you have it. So you all, let me show you this image. So when you're doing your EKGs and you're going to learn about your P waves, your QRS complexes, and your ST segments, if you look at that nurse's facial expression, because when you showed her that EKG strip, when you showed her the leads, look at V4. You see those tombstones? You see that elevation? That is a sign that the patient is having myocardial infarction. And let's break that word down. Myo means muscle. Cardio refers to the heart. Infarction means death. So a part of the heart is dying due to a lack of oxygen and blood supply. So that would be a medical emergency. And yes, that can be detected when you're performing an EKG. Question number 25. What does a widened QRX complex indicate? Is it A, atrial fibrillation, B, bundle branch block, C, normal sinus rhythm, or D, bradycardia? And I'll accept 2 answers for this one. A widened QRX complex. Nargisa says C. Natasha says D. Nancy says D. Ruth. Chief says A and D. Ruth says D. And for you all, the responses that I would accept would be B and D. So a bundle branch block is what happens when the QRS gets wide. And as you all are aware, that means that it's taken a long time for the electrical responses to go through the heart, which would normally mean the person's heart rate would be slow. All right, so whenever someone has a widened QRS complex, what we'll normally see on the monitor is this wide QRS. We'll usually see a slower rhythm, which if the heart rate's less than 60, we refer to that as a bradycardia. But whenever you see it, I need you to automatically assess your patient. Most of the time, they're going to be fine. But I want you to think meds because more than likely they've taken digoxin or a beta blocker, the LOLs, which have slowed their heart rate down, causing this bundle branch block. So think meds and think patient safety. If someone has a widened QRS complex with a slow heart rate, don't stand them up. because that means they have low cardiac output, and that also means that they are going to be at risk from falls, because when you stand them up, their blood pressure can drop. Question number 26. What is the proper order of draw for blood collection? Oh, this is hard, but we're going to simplify it today. I'm not going to read all that. Is it A, B, C, or D? I sent you into the room to draw blood, and you need to collect 3 different tubes of blood. You have to know your tube order. Uh, I don't know, Chief. I want to say, I don't know. I want to say Friday, because my schedule kind of sucks right now. And so for this one, looks like Ruth has it, you all. So you want to start off with the blues, the coagulation studies. But what this slide did not include were blood cultures. So anytime you have to collect the blood cultures always go first. And so the order of draw is blood culture, then blue, red, green, and lavender. And if you have to do a gray top, usually that's for lactic acid, your lab requisition slip will normally tell you to put it on ice. So make sure you read those slips. And whenever you need help, don't be afraid to use your materials, to use your resources. A lot of the patient care techs will walk around with a badge like this, with a sticker like this attached to the back of their badge to help them remember the order of draw. You don't have to remember everything. You just have to do the best that you can and utilize your resources. Question number 27. Which of the following can cause hemolysis of a blood sample? Hemo refers to blood. Lysis, we're destroying it. So which of these can destroy your blood sample? Is it A, using a needle that is too small? B, not allowing the alcohol to dry? C, vigorously shaking the tube? Or D, all of the above? Chief says D, Natasha says D, Ruth says D, and you all are absolutely correct. And so this image is how you're going to feel when you just stuck a very difficult patient and you send that blood specimen down and lab says, we're sorry, we cannot accept that specimen. Try again. So so as you're learning your phlebotomy skills, you want to do everything in your power to just be conscious of things that you could do. Sometimes we're using the wrong size needle. Sometimes we're just shaking things too fast, or we're not shaking or inverting the tubes at all. But if we mess up a blood sample, the blood still has to be collected. So that means you have to go back and stick that patient again. And thus you get an emoji like this, an upset PCT who's really busy, who has to try again. Question number 28. What is the recommended needle gauge for adult venipunctures? Is it A, 16 to 18, B, 20 to 22, C, 23 to 25, or D, 25 to 27? When we're talking about the gauges, we're talking about the opening in that needle. How big do you want that opening? Do you want it huge or do you want it really small? And yes, Adam and Ruth, you all are absolutely correct. You all, so proud of you. We're going to do B. We're going to use a 20 to a 22 gauge. And so for this one, the numbers are opposite. The smaller the number, the larger the needle. The higher the number, the smaller the needle. And so that will make sense on the next slide. So a 20 to a 22 gauge needle is what we normally use for venipuncture. But I want you to read the packaging. So I know some of you young people are going to be like, oh, Eunice, blue means this gauge and green means this gauge. Look, I'm not going to remember it. Been a nurse for 25 years. I'm not going to remember it. I'm going to look at my packaging. And my packaging is just not only going to tell me the gauge, it's also going to tell me the needle length. And you also need to be looking for the expiration dates. Always look at the expiration dates on things, especially when you're going to be inserting them into someone's body. But a 20 gauge is the average size, but we can also use 21 gauges. If you're using a 16 or an 18 gauge, either you really dislike that person, or that's usually for IVs when we have a trauma patient and we have to dump a whole bunch of blood into their body at one time. That's when those trauma nurses will use 16 and 18 gauge needles. Question 29. What is the proper technique for drawing blood from a patient with fragile veins? Is it A, use a larger needle, B, use a butterfly needle, C, apply extra pressure, or D, draw from the hand veins? Or little kids, that's right, Chiefs. So little kids will be the really, really small gauge sizes. So your 26s and your 28s. And everyone got this right. We're going to use that butterfly device. So using a butterfly needle is recommended for patients with fragile veins. So it's B. Something else that you all don't consider is that if we already have a patient who has anemia and she has fragile veins, so anemia means she doesn't have enough red blood cells. She has a low blood cell count. Sometimes don't use the adult valve. Use the pediatric valve. You would call the lab first. Also speak with your nurse and say, hey, Miss Eunice isn't giving me enough blood, but I do have enough blood to fill up a pediatric valve. And sometimes they will accept that, especially on our elderly patients, so they don't have to be stuck so much. Question number 30. How often should the inner cannula of a tracheostomy be cleaned? Is it once a week, every day, every 8 hours, or as needed? And I'll accept 2 answers for this one. Chief says C. Claudia says D. Nancy says D. All of those responses are correct. So at least once a shift and as needed. And so yesterday in the tracheostomy video, we know that we don't use like peroxide in our facilities unless your doctor specifies and says peroxide. What we're going to clean with instead is sterile water. But when you're in the hospital, we really don't do a whole bunch of cleaning of the inner cannulas. We just replace them. So your nurse can literally just take one out and put another one in. But that would mean that we can keep that airway open, and it's going to help prevent mucus plugs from occurring. And for those of you all who are just coming or attending and watching the video, we do have patient care tech certifications. They're online courses. Unfortunately, they're only available for U.S. citizens. In order to become nationally certified, you must reside in the U.S. And if you'd like more information, you can call 877-225-7151 or visit our website, which is fltraining.com. Question number 31. What is the recommended suction pressure for tracheostomy suctioning in adults? That's right. You have to turn that dial. And if you turn it up too high, you're going to irritate their trachea. If you turn it down too low, you're not going to get enough of the mucus up. So is it A, 60 to 80 millimeters of mercury? Is it 80 to 100, 80 to 120, or 120 to 150? Over here doing my nurse dance because I know you're going to get this answer right. I know you're going to get it right. And blossom right off the bat. Yes, it is C. So Blossom, Nancy, and Karen, you got it. It is 80 to 120 millimeters of mercury. So before you even connect the tracheostomy to the catheter, before you connect it, you put your finger over the tube and you want to turn it, and whenever it's sucking your glove finger, that's when you'll be able to monitor the gauge, and it's going to let you know that, hey, right now you have it on a low suction. You have it at 60. You can take it up to 80, connect your actual catheter that you're going to use to suction, and then you can attempt the suction. If you don't feel that you have enough force or enough suction, you can always increase it, but never go beyond 120. If you have to go beyond 120, talk to your nurse and let her do that. Question number 32. What is the purpose of using a tracheostomy mask? Ooh, we haven't talked about this. Is it A, to assist with speaking, B, to provide oxygen therapy, C, to prevent infection, or D, to secure the tracheostomy tube? You can't beat me up. Let's see. I think you all are looking up the answer. And I don't want to mispronounce it. It's either stary or starry, but you're absolutely correct. It is B, everybody. So this is what a tracheostomy, that should say mask and not max. This is what a tracheostomy mask looks like. Sometimes we refer to it as a tent, but it actually is connected to a longer, like accordion type tube. It's also going to be humidified, and it's going to provide high flow oxygen to the patient's trach, because remember, this is where they're breathing now. So they would not have a nasal cannula. Their oxygen would be attached or at least over their tracheostomy tube. And I'm so proud of you. Oh, I am blessed. Great job. Number 33, how should you position a patient with a tracheostomy during suction? Everyone should get this right. Is it supine, prone, semi-Fowler's, or Trendelenburg? How are you going to sit those patients? Prone is face down, so it won't be prone. Supine, take the U out, they're laying on their spine. Why would we have a person who has respiratory problems laying flat? So if you chose C, semi-Fowler's, you're absolutely correct. And so here are those different positions. Remember, prone is face down at no point. Especially if they don't have cardiac monitoring, respiratory monitoring, should your patients be in a prone position because we can't see their chest rising and falling. We usually don't keep them in a supine position for long. We use that when we're repositioning them. We will put them on their side every now and then, but even when they're on their side, if they have a tracheostomy tube or a G tube, they still have to be in the semi-Fowler's position. So the head of the bed must still be elevated even if they're on their side. Trendelenburg, we never put somebody who has respiratory issues in Trendelenburg, period. I don't care if they are short of breath and dizzy. If you put them upside on their head, oh my God, and they have respiratory issues, you made their respiratory issues worse. So Trendelenburg would be for somebody who maybe has low blood pressure without any respiratory issues. And you would never put a person in Trendelenburg without your nurse telling you to do so. Question number 34. What is the primary sign of a tracheostomy tube blockage? And we know the answer is going to be D. Is it increased coughing, decreased oxygen saturation, difficulty breathing? And this one was super easy. We know it's D. And so this is a part of the team. So if you notice any of that, you're going to be notifying your nurse. We're going to question number 35. How often should a gastric tube be flushed? Remember, we want to prevent it from getting clogged. So is it before and after feedings, every hour, once a day, or only when clogged? Why do you want to flush this gastric tube? And also, this patient is dependent upon you to receive their hydration. So if all you do is connect it and then attach ensure, you're ensuring that they're probably going to be dehydrated. So you also want to be flushing it, just not to prevent clogs, but to also provide extra water for this person. So if you chose A, before and after feedings, you are absolutely correct. You take that irrigation syringe, you're going to fill it with water, whatever the dose is that the nurse or the doctor recommends, and you're going to be flushing it before and after your feedings. And you may also have to provide some intermittently to give them extra hydration throughout the day. Question 36. What is the appropriate action if a patient with a gastric tube shows signs of aspiration? And if you don't remember, when someone aspirates, that's when food or fluid leaves the stomach, travels up into the trachea, goes down into the lungs. So what do you do if a patient who has a gastric tube shows signs of aspiration? Do you stop the feeding immediately, suction the airway, position the patient upright, or all of the above? This one's a tricky one, but I see I can't trick you all. So for this one, it sounds like it's a lot of work, but you're doing D, all of the above. Can I tell you that when a patient you've laid flat starts to cough up tube feeding, It's like you jump into action, you press that button, you call the nurse, you sit them up, you get the yonker, you start suctioning out their mouth like right away. So literally in like 30 seconds before the nurse can even get into the room, if there's a good patient care tech, you're already helping to make this patient better. So all of the above is the correct response for that question. Question number 37 is a freebie. Have you learned anything while watching this practice test? I need all A's or my feelings are going to be hurt. So A is yes, and you're going to give the video a thumbs up. But then there are some people who I know there are some people who are like C. You just want to know if I'm going to mess up or say a bad word. So so yes, everybody, thank you for the C. Thank you for the A's. And so yes, give the video a thumbs up. And we have a few more questions to review. And I'm so proud of you. Thank you all for hanging in here with me. I know this is a longer video. Question number 38. What is the primary purpose of checking gastric residuals? Is it A, to ensure the tube is in place, B, to check for digestion issues, C, to monitor for feeding intolerance, or D, to assess for infection? Read those carefully. Which one do you think? I've been giving you hints. Why do I need my tech checking the residuals when someone has a gastric tube and they're getting fed? Yeah, this one's harder. I haven't seen the correct response yet. So revealing the answer in 3, 2, and for this one, it is C, to monitor for feeding intolerance. So imagine this patient who has a gastric tube and we have their boost, their tube feeding going through. And we gave them a whole can of tube feeding at 8 a.m. And we come back an hour later and we check the residuals. And she still has a full can of tube feeding remaining within her stomach. You keep pulling, you're doing your residuals, you keep pulling. And as a reminder, whenever you are checking someone's residuals, you do not throw the contents away. You have to put that stomach contents right back into their body. So we need to give her body time to digest the food. You want to notify the nurse right away because she should not have 240 mLs in her stomach. The nurse will have to notify the doctor, we'll stop the tube feeding, and then we'll probably lower the rate also. So the reason that you check for the gastric contents is to monitor for feeding intolerance, and we'll have to adjust the rate based on your findings. Question number 39. What is a critical step in preventing infections in patients with invasive devices? That can be a nasal gastric tube. It can be a tracheostomy. Is it A, hand hygiene, B, regular device cleaning, C, proper dressing changes, or D, all of the above? Yes, 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 yes. Great job, team. It is all of the above. All of those steps are critical in preventing infection. Question number 40. You are now ambulating a patient who is at risk for falls. What should you do? Make sure you let me read all of the questions, all of the responses before you give me an answer. Is it A, walk behind the patient and allow them to set the pace? B, use a gait belt and walk behind the patient, supporting them as needed. C, ask another PCT to help you walk the patient. Or D, have the patient walk barefoot to prevent slipping. And I'll give you about 7 seconds to put your responses in. So Dallas, Claudia, Chrissy, Nancy, everybody gave me the right response. No one got tricked. No one chose C. The correct response is B. You're going to use a gait belt and walk beside the patient. And the rationale is that using a gait belt provides additional support and stability, reducing the risk of falls while allowing you to assist the patient as needed. You can ask for help, but even once you ask for help, you still have to use a gait belt because otherwise you two are just dragging the patient around the room by their arms. And because you're not supporting their core, they are still going to get dizzy. They're going to lose their balance. They're going to hit the floor. So using that gait belt prevents falls. Question 41. Which of the following interventions is most effective in reducing the risk of falls for a patient who frequently tries to get out of the bed unassisted? Is it A, apply wrist restraints to prevent the patient from getting out of bed? B, keep all four side rails up at all times? C, encourage family members to stay with the patient at all times? D, place the bed in the lowest position and activate the bed alarms. Miss Lucas, every time you put her in bed, she just gets right back up. She will not listen to you. She will not call for help. How are we going to prevent her from falling? And Claudia, good luck in advance on your test. It's right around the corner. And for everybody who chose the correct response, which was D, great job. So placing the bed in the lowest position reduces the risk of a fall, and also those bed alarms. It's nothing more than like a pad, or sometimes the mattress can detect the movement. And if a person moves too much, they shift too much, it sets off an alarm. And when you hear that alarm, you need to get to that room right away, because that means that your patient who should not be getting out of bed unassisted is trying to escape the bed. So you go in that room. Question number 42. What is an important consideration when drawing blood from a patient on anticoagulant therapy? Is it A, use a larger needle? B, apply pressure for a longer time after the draw? C, draw from a different site? D, use a tourniquet for a shorter time? And I love you all. I didn't even think about this one having two options. And you all are correct. You all are smarter than a nurse today. So for everybody who put D, I will also accept D. But yes, apply pressure for a longer time after the draw, but then also don't hypoconcentrate the blood by keeping the tourniquet on for a long time. So both of those are actually correct. Something else that I want to make you mindful of is when you go into that room and you see those IV bags hanging on the IV pump, some of those could be blood thinners. So if you're going to be drawing blood, you need to know the type of medications your patients are receiving, because if they're on aspirin, that thins the blood. If they're on heparin, Coumadin, those also thin the blood. And so if your patient's receiving a heparin infusion, while you have to draw blood, it's a good rule of thumb to go speak with the nurse to see if she can just pause the infusion while you draw your blood. Otherwise, you're getting a heparin level in the arm that's receiving heparin. And so that means that that arm is going to have it's going to be a false high reading. So as you progress, as you become a PCT, as you progress and start drawing blood, this will all make sense. But for right now, we're just giving you a good introduction. Question number 43. Which of the following symptoms should be immediately reported for a patient on blood thinners? Is it bruising on the arms and legs, a slight headache, blood in the stool or urine, or mild joint pain? And Suzette, my email address is admin@fltraining.com. I'll put that in here. When you say contact me, I have an office staff, so they usually filter the questions and then I'll respond if absolutely necessary. But admin@fltraining.com. And for everyone who chose C, you are correct. So let's talk about what blood looks like in the stool. So if the blood has been digested, if it has mixed with stomach acids, it's not going to come out red. It's going to come out black. It's going to be a lot of it, and it's going to smell horrible. That would be a sign of a gastrointestinal bleed. However, if it is red, that means that it hadn't been digested, and it is probably more hemorrhoidal, or maybe the person strained. Either way, if it's abnormal, you want to notify your nurse. But black is also an indication of blood being in the stool, but it could be that they're on iron supplements, or it could be that they had Pepto-Bismol. So we don't want to upset the patient, just notify the nurse. And we're almost done, team. And this is the number. I know someone asked for the number again. It's 877-225-7151. And you did a miraculous job. I am so proud of you. And I'm waiting for a few more babies to contact me to tell me that they passed their test today. Again, this is Nurse Eunice. I will be on before the weekend, more than likely Friday, and I'll do another CNA and PCT practice exam. So you all have a wonderful rest of the day. And thank you all for watching. I hope you learned something new. Bye.